Welcome to Parasitic Diseases. Today we're going to discuss another form of Leishmaniasis, a more serious form than the one we discussed last time, which was the cutaneous form of Leishmaniasis. Today we're going to concentrate on mucocutaneous Leishmaniasis. And as you see in these two pictures that are helping to illustrate this organism, and as we'll see, there's actually two organisms that are involved here. The person that I'm using the cursor on right now, the arrow, this entire front of his face has been eroded away by this parasite. This gentleman on this picture, this clinical picture, shows a much smaller lesion developing. And that's not because this organism is different than this organism. It's because this patient turns out to have access to healthcare, and this patient doesn't. The organism in question is called Leishmania braziliensis. It's found only in the New World. And we see depicted here from a wonderful article in The Lancet, 2006, where Leishmania braziliensis is actually found. And the braziliensis part is shown here at the top, the clear zones. All of this represents braziliensis. Notice the editor in charge of our parasitic diseases noted a spelling error that we detected from the Lancet article. It's possible that the name changed from 2006 to 2017. We doubt it. So I just wanted you to know that we want you to all be up to date. It's called Leishmania panamensis, not panamonensis. That's an organism that only causes cutaneous leishmaniasis. So let's go back now to the one in question. The discovery of this organism involved two widely recognized scientists in South America, Dr. Carini, who was also instrumental in finding the organism that causes pneumonia in immunocompromised people. It's called Pneumocystis carini, and it was named after him. And he was the one that noticed the missing nasal septa in early stages of Leishmania braziliensis and described the clinical manifestations and is given credit for that, obviously. The organism itself was harder to identify as to what was causing this. And Dr. Viana, who the entire subgroup of organisms in South America that cause this infection was named after, did careful microscopy and, of course, identified the mastigotes in the tissues. The life cycle of this organism is a little bit different than Leishmania tropica and its relatives that causes cutaneous leishmaniasis. In this case, most of the mammals of South America can harbor the organism and that may suffer from some form of mucocutaneous leishmaniasis, but it's humans that it's most recognizable in as a clinical syndrome. Again, the sandfly begins the infection by depositing the organism in the bite wound. The promastigote stage, the flagellated stage is deposited along with all the secretions of the salivary glands of the sandfly itself. So let's start with the sandfly introducing the organism as a metacyclic promastigote. The same process occurs for all Leishmania. They all start the same way. But the outcome is different in this case. What we can see next is the organism forms a lesion in the skin and begins to infect invading phagocytic cells of various kinds. And the lesion at that point then sort of disappears. And we would then wonder, well, maybe it was a mild infection, or maybe I have immunity, and as a result, I didn't get the full-blown cutaneous leishmaniasis like I would have if I hadn't been exposed before. All kinds of thoughts of a person could go through their head at this point to rationalize why they weren't exhibiting clinical signs and symptoms of what they would suspect ordinarily as being a leishmaniasis infection. But what's happening is that this organism is now traveling throughout the body in these macrophages. They leave the area of infection and they travel to various parts of the body. And because Leishmania braziliensis is known as muco-cutaneous leishmaniasis, these macrophages relocate with their load of amastigotes to areas like the mucous membranes of the mouth, the soft palate, for instance, or the urogenital tract. And there the infection manifests itself again, only this time with much graver consequences for the host than if it were just a cutaneous infection. The result of the migration of infected macrophages to various areas of mucocutaneous junctions is very simple. The same manifestation that you would get at the cutaneous lesion now occurs at the mucocutaneous lesion, only, as I said, with much more serious consequences. As a result, if you are living, let's say, in the middle of the Brazilian jungle as part of a native tribe that has never seen the light of day with regards to civilization, these infections can progress to the point that the entire soft palate of the oral cavity has been eroded away by the organism. Notice I said just the soft palate, not the hard palate, the soft palate. There's no pain associated with this either. So even though it looks grotesque, to the person experiencing it, it doesn't feel grotesque. But to other people, of course, it's a very upsetting thing to see. And for some societies, these people are ostracized and they're marginalized. And they end up dying from exposure or from malnutrition, which is a very sad ending to a young person's life, indeed. The organism does not go on to resolve as the cutaneous form does, and it gets more and more serious. And of course, it begs for a medical intervention. In order for this infection to continue, an infected sandfly will find these areas of inflammation, sample the environment for blood, of course, acquire the infected macrophages, and the cycle inside the fly then ensues over the next 10 days, resulting in the completion of the life cycle. And now Dr. Daniel Griffin is going to give a clinical vignette illustrating the pathogenesis of this infection.
This is a 55-year-old female from the highland Central Valley area of southern Peru near Cusco, coming in with a lesion inside her nose. She works in farming and reports no prior skin lesions, but does have multiple hypopigmented scars on her body that she attributes to trauma. She does report many years of bloody nasal discharge. I'm going to point out a few things. Highland, southern Peru near Cusco, a lesion inside her nose, multiple hypopigmented scars, and many years of bloody nasal discharge. This should be starting to get us to think about the different features, different clinical features of mucocutaneous leishmaniasis. A little more about this woman. She's 55, but she's still working in farming. No travel, just this area around Cusco. The only time she travels is to come down to Lima to see the doctor. Quite a bit of exposure history, lots of insect bites. There's cattle, there's dogs, there's llamas, there's sheep, there's alpacas, and there's guinea pigs. People like to eat guinea pigs in this part of the world. So, and here, I'm going to bring our cursor over. There's actually an ulcer, an ulcerated lesion inside the nose, and it's on the nasal septum. And this has been this lesion that has been bleeding. We talked about last time the typical crater form ulcer. Now inside the nose, it's going to be hard to see the actual lesion. And this is not a primary lesion that we're looking at. We're suspecting, based upon the hypopigmented areas, that this woman at some point had a typical cutaneous leishmaniasis ulcer, and now is having the metastatic mucocutaneous disease. And unfortunately, progression can occur without proper treatment. And as we discussed in our prior lecture, even if you treat, you minimize, but you do not completely remove the risk that a cutaneous infection with the particular mucocutaneous subspecies might eventually lead to mucocutaneous disease. This is showing a gentleman that we've seen before with a lesion on the mucocutaneous border here. This is this unfortunate young man with the anterior part of his face severely infected or affected. And this is this ulcer that we're seeing inside the nose. Now, what about diagnosis? And diagnosis here, I want to sort of put a little sort of asterisk on this, is two things. One is, as we talk about with the other forms of leishmaniasis, with cutaneous leishmaniasis, the organisms are found only in the living tissue at the raised margin. And it's, again, regardless of the age of the lesion. You do not want to go biopsying right in the center of these things. You want to get right on the edge. This tends to be, I'll say, a paucipathology disease in that there are not a lot of organisms. There are going to be very few. What we're mainly seeing is an exuberant immune response to few organisms. So with mucocutaneous leishmaniasis, definitive diagnosis is by nucleic acid amplification testing. The organism is very difficult to find in biopsy. So if you do biopsy in here, you're going to probably cause more damage than help. You're also very unlikely to get the actual organism seen. Culture, again, is very, very tough because there are very few organisms here. So when you're thinking about mucocutaneous disease, it's really going to be nucleic acid amplification testing. And I'm going to sort of keep harping on that. I don't want anyone to go taking big biopsies when they're thinking about this. So you're not going to see the dot and dash. Very rarely. You really want to be doing nucleic acid amplification testing. Culture, again, there's a few places that can do this, but again, this is a technically challenging approach. It's also something with low sensitivity because there are so few organisms in these lesions. So this is going to be our friend here. It's going to be the nucleic acid amplification testing approach. This is critical for making the diagnosis. And this is going to be broad when we're seeing mucocutaneous disease, but this is also going to help us up front to know when we encounter cutaneous disease, whether or not we're worrying about a species with mucocutaneous potential. Species identification is critical when we're trying to decide whether or not we need to be concerned about mucocutaneous disease. And I'm going to bring everyone's attention to the big three, and then I'll mention as well. So the big three types of Leishmania that can lead to mucocutaneous leishmaniasis are 1, Leishmania braziliensis, 2, Leishmania panamenensis, 3, Leishmania guyanensis, and very rarely it has been described, but amazonensis as well. Now, these certain species have different frequencies, but do have the potential for mucocutaneous spread. Now, what about treatment? Now, there's multiple therapeutic options for the mucocutaneous species, but we're not going to be looking at local destruction. We really want to treat with systemic disease. The understanding of this disease is that it has spread. It's a metastatic, and so it is going to require systemic approaches. You can use azoles, or those have been used. Miltefosine, I would say, of the oral drug therapies, is the one that would be the most agreed upon as a reasonable therapeutic approach in the context of mucocutaneous disease. But in general, we're going to be doing parenteral therapy here. The pentavalent antimonials and the different forms of amphotericin are going to be the main agents that we're using to treat here. Complicated cutaneous leishmaniasis being sort of a very advanced disease, and we'll see some of the criteria here. And mucocutaneous leishmaniasis warrants systemic therapy. So what do I mean when I say complicated cutaneous? So first off, if you have an infection with one of the species with metastatic potential, and I listed them again here. The other, and we saw this with a gentleman who had multiple lesions. So if you have more than 4 cutaneous lesions, it's suggested that we do systemic therapy. Certain locations, the face, the fingers, the toes, the genitalia. If the host is compromised, if we're not going to have the host response helping us. The other would be failure to resolve. It's been greater than 4 months. And one of the things is that most leishmaniasis infections will resolve on their own. But if it's been more than 4 months, it's not resolving, maybe it's even failed local treatment, then you want to start looking at systemic treatment. The other is size of lesions. Now, 4 centimeters, that's a big lesion. And a lesion that size is another context in which most of us would recommend systemic therapy. And the last, and this is mucocutaneous. If you have involvement of mucosa, then this always warrants systemic therapy. Now, just a little details on the options. And this is, we have complicated or mucocutaneous. Miltefosine, this is an oral drug. It's actually quite expensive. An adult is going to be taking this 50 milligrams 2 to 3 times a day for 28 days. Parenteral therapy, and this will depend, but in some parts of the world, we'll be using pentavalent antimonials. These are often a little bit less expensive, so that drives it in certain situations. The 2 forms of amphotericin, straight regular amphotericin is less expensive, but there's greater toxicity. The liposomal amphotericin is going to be more expensive, but is going to be much better tolerated. And I'll say definitely an inferior option based upon what we know is IV pentamidine. This could be IV or IM. That is another option, but it's felt to be inferior to the others. And in some situations, we'll actually be combining therapy. Of note, no therapy is 100% effective. We're not sterilizing. We're treating disease. We're decreasing the parasite burden. But unfortunately, persistence of infection beyond the treatment period has been documented repeatedly. And certain patients, unfortunately, will require repeated courses of therapy. They'll be treated. The lesion will resolve. A year or 2 might go by, and then might be back again for another course of treatment. Now, as far as our patient had a PCR from scraping at the edge of the ulcer, which was positive for Leishmania braziliensis. The patient required repeated courses of parenteral therapy, amphotericin B with resolution with therapy, and then recurrence. So this is, as I described, this is a patient who's treated, she gets better, but has relapses and has to be retreated.
So it's better to prevent and control than it is to treat, obviously. So public health is a major way of interfering with the transmission of these Leishmanias. And the difficulty here, of course, is the fact that they all have reservoir hosts. It's not just a human infection. It exists in nature as well. When we're traveling, of course, we can avoid it by using a DEET spray to spray all over exposed skin areas when we travel in natural settings, let's say that we're doing an eco tour in a jungle. We can sleep under insecticide-impregnated mosquito netting, of course, to keep out the biting insects during the evening. Not so much of a problem with sandflies because they usually bite just after sunup and just before sundown. And we can avoid this infection almost altogether if we would create a wide enough buffer zone between settlements and the edge of the forest, because the sandflies, because they're happy to bite a monkey as well as a human, would settle for a monkey in each case, provided, of course, that there were only monkeys, but of course there are us too. Encroaching into these areas is the way we take this infection and bring it back to the human side of things. Vaccines are always an option. None are available at present. I'm sure that there's a lot of work that's going on to try to develop them, but so far, no luck. To learn more about this kind of leishmaniasis, the cutaneous, mucocutaneous leishmaniasis, I should say, there are several good references that might lead you to some literature which may explain further why a vaccine hasn't been developed so far. So next time we'll finish up with the Leishmanias by a discussion of the visceral leishmaniasis form, which is, of course, the most devastating form. Thank you for listening.